Hello, I'm Carla Ugoli, CEO of Dermodiagnostica Limited Company, a private enterprise committed to continual education on dermatopathology. I'm pleased and proud to present the video of the 14th Dermatopathology Self-Assessment Workshop. The course was held in Rome between the 13th and the 17th of September 2016. The course consisted in the direct vision of about 350 histological slides for the first 2 days. Cases were then discussed for the following 3 days. The video I'm presenting to you includes the complete recording of these 3 days of discussion and case presentation. The faculty guests were Philip LeBoit of the University of California at San Francisco and Professor Lorenzo Cerroni of the University of Graz in Austria. These two distinguished teachers are among the most respected leaders of the contemporary dermatopathology. In the course, they have made a contribution of outstanding value, as remarked by all the participants. What it follows are 15 minutes picked up from more than 10 hours of the video recorded lectures.
The first of the melanocytic cases that I'll show is a consultation that I got, and it was a consultation solely on a re-excision specimen. So they sent this re-excision specimen to me with a history that it was a re-excision of a melanoma, and they didn't send the slide of the original biopsy. And their question was, we think that there's melanoma in situ here. How close to the margin do you think the melanoma in situ is? That was the question that the pathologist who sent this to me had. And the slide shows a re-excision specimen with a fairly subtle melanocytic proliferation. We have elongated ridges, increased numbers of single melanocytes. In some areas, there are clefts around them, so it has they have a pretty prominent pattern. There's one focus here with a cornoid lamella almost that's sticking out, but there's actually epidermolytic hyperkeratosis there. And then some other areas really look the same. So the question here is, what are we looking at? Are we looking at residual melanoma in situ? Are we looking at a junctional dysplastic nevus? Are we looking at simple lentigo? These changes went almost over the entire surface of the specimen. So what I wanted to do when I saw this was to really have some sense of what the patient's original melanoma looked like. And the pathologist who sent this case as a consultation said, we don't have the original melanoma, that went to a different laboratory. So I called up the laboratory that the original biopsy went to, and this is what they sent. And this is why it's so hard to find the scar from the initial melanoma, is that the initial biopsy was a fairly thin shave, and it shows a mostly nested pattern of melanoma. I think the diagnosis is correct. You could think, well, could this be a junctional dysplastic nevus? But the nests really vary too much in size, and they're distributed very irregularly. There's this very extensive area where there's clefting between the epidermis and dermis. So I think the diagnosis was correct. The cells of this melanoma are large and are spindled and have large hyperchromatic nuclei. So this pattern doesn't really look anything like the lentiginous pattern that's in the re-excision specimen. And even as we go to the edge of the biopsy of this patient's melanoma, there's no lentiginous pattern. It's almost entirely nested with these large spindled cells. So that really should make one think, well, perhaps what we have in the re-excision specimen is not the patient's, is not residual melanoma in situ, but it may be something else entirely. So I went a little bit further and called up the dermatologist who did the original biopsy of the melanoma and said, you know, tell me what this patient looks like. Did they have a pigmented lesion on a background of clinically normal skin, or do they have lots of lentigines? And the answer was, why don't I send you a clinical picture? Because the guy actually didn't remember. So he sent me the picture, and it's apparent, here's the original melanoma, here's where he's marked for re-excision, and this is what the rest of this patient's skin looks like. So if you look at this, no matter where you would do the re-excision, you would probably include some of these little pigmented lesions around. So this represents, I think, a re-excision specimen where there's no residual melanoma in situ. What we have instead are hundreds of little lentigines that, and some of them were coincidentally in this patient's biopsy. So interpreted
it looks like an easy story, no? You find this, and it's annular lichenoid dermatitis of youth. Now I show you case 53 is a man, 33-year-old, band-like infiltrate, decapitation of the retroregis focally, very typical with psoriasiform hyperplasia. So decapitation of the retroregis with lymphocytes, necrotic keratinocytes. That's really exactly what we've seen now in the other cases that I showed you of annular lichenoid dermatitis of youth. But remember, they described it also in adults. Again here, small area of this squaring off to the retroregis. Again, a pattern of CD helper positive lymphocytes, some histiocytes, some or many CD8 positive cells as well. And this is the patient with these lesions here, not annular, looking completely different than the one that you have seen before. They don't look like clear-cut mycosis fungoides, but if you know these patients better, this is August 2013, February 2014, November 2014, April 2015, the lesions are stable, coming and going with the treatment, and that's a second biopsy. And now you find the conventional mycosis fungoides with diarrhea, microabscesses in the epidermis. So this is annular lichenoid dermatitis of youth like mycosis fungoides. And if you ask me what is ALDI, I don't know. I have great doubts that this disease really exists. Still, of course, there are publications. There is a good follow-up of the few patients that have been described. So to my eyes, one should keep following up these patients. So remember, mycosis fungoides may show the identical squaring of the retroregis like in ALDI in some biopsies. So the correlation with the clinical picture is crucial. Never make a diagnosis of ALDI just because of this decapitation of the retroregis. The exact nosology of ALDI is completely unknown. Nobody knows what it is. It said it is inflammatory, but it's a disease where nobody knows the etiology, the pathogenesis, why it comes, when it goes, will it come back or not. And in adults, you should make this diagnosis really upon compelling evidence, the classical clinical presentation, the classical histological presentation. And I suggest to follow up children with ALDI with long-term follow-up, and also adults, of course, because I'm not really sure what this really is. That's my personal opinion. Case 57, now we go to tumoral infiltrates really. It's no longer early mycosis fungoides-like looking lesions. It's a 75-year-old man with this dense nodular infiltrates involving also the subcutaneous tissues. And here you see epidermotropic lymphocytes with atypical features with angiotropism and angioinvasive lymphocytes. You see here this cluster of lymphocytes around vessels with tropism of the lymphocytes for the vessel wall. So in these cases, of course, you need a complete phenotype. You cannot just make a diagnosis by histology. So that's CD3, where you find also the intraepidermal lymphocytes. CD5 is completely lost. This is CD30. This is CD56. This is granzyme B and TIA1, so it's clearly cytotoxic. And this is Aber1. So it's Epstein-Barr virus strongly positive everywhere. This is beta F1, which is basically negative, and gamma, which is also negative. This is the patient with these plaques and small nodules on the trunk. And then when I made the diagnosis of extranodal NKT cell lymphoma nasal type, so the patient was seen as an inpatient, and when you looked at him, that's there. It's a big ulcer in the palate, so this is an oropharyngeal typical nasal type extranodal NKT cell lymphoma with skin manifestation, which were just the first and the first manifestations that were recognized as lymphoma in this patient. We can argue many times why these patients don't come before to somebody to show this ulcer, but this is the reality of things, that sometimes patients come with things which are incredible, and just for one small nodule on the skin, and yet they have huge things somewhere else. That's, for me, it's very difficult to understand, but that's what happens. So this is the new WHO classification of 2016 and 17. It's basically the same. Nothing changed in this setting. In the diagnostic realm, it's a nasal, perinasal lesions are quite common. The so-called lethal midline granuloma. Palatal ulcers are also quite common if it's a long-standing oropharyngeal lesion. Persistent fascial swelling is a relatively common presentation. It's subcutaneous involvement, and then you have this persistent edema, which is not edema, of course, of the face. In most cases, the lesions on the trunk and extremities are clinically nondescript. They are identical to mycosis fungoides or to other lymphomas. The epidermotropism is variable, but you have seen in this case there were really clusters of epidermotropic lymphocytes. The subcutaneous involvement is variable. There is frequent but not invariable angiocentricity, angiodestruction. Sometimes may mimics an inflammatory dermatosis. One of the cases that you had in the set was extranodal NKT cell lymphoma, which was a very sparse perivascular infiltrate. The cell morphology is variable, small, medium, or large. This is one of the few cases of lymphoma where it doesn't matter how large are the cells, it's still the same lymphoma, the same classification, there is no grading, there is nothing, it's just one diagnosis. You don't need to pay attention to the morphology of the cells, but the phenotype is crucial. They're usually CD2 positive, CD3 epsilon positive, which is a cytoplasmic positivity, but in truth they are natural killer cells, so CD5 is negative, other markers of T cells are negative. CD56 is commonly positive, but in the skin can be negative. It's a cytotoxic lymphoma, and you must demonstrate it's a prerequisite positivity for Epstein-Barr virus by in situ hybridization for AGA1. CD30 positivity, like in this case, you can find it in 30% of cases. So if you make inappropriate phenotypic investigations in these cases, you can go really in wrong directions. In these cases, like in epidermotropic lymphomas, you really need a large panel of antibodies. You must test all the possibilities there are in the differential diagnosis. You must rule out all the other things, and that's crucial. So BB positivity and expression of cytotoxic proteins is a prerequisite for diagnosis, is a cytotoxic EBV-associated lymphoma. And there are a small number of these cases which are really T. This is why it's called T and K, but the majority is NK.
In case 20, it was a 39-year-old man with a lesion on the chest. In 2008, a diagnosis of melanoma was formulated, and I saw the cases in consultation. On my suggestion, the technique of sentinel lymph node was performed. Since the tracer went in two different directions, two sentinel lymph nodes were taken into the axilla. Both of them were negative. 2 years later, a lymphadenopathy on the right armpit became clinically apparent. 18 lymph nodes were removed, 2 of which were metastatic. The year after, the patient developed a widespread metastatic disease, and the same year, the patient died from his melanoma. My interpretation of the cases is an anevoid melanoma with some features simulating a deep penetrating nevus, with features of plexiform melanoma. Here you can see immediately that the silhouette of the lesion has many worrying details. This bizarre polypoid vegetation is surely to be studied carefully. As shown already at this magnification, the silhouette of the epidermis is uneven. You see from the left to the right that the interpapillary rete ridges are still respected or even elongated. Then there is a section in which these papillary rete ridges are lost, then reappear, and then disappear for good this time at the end of the specimen. Just this asymmetrical epidermal silhouette should prompt the suspicion of a malignant melanoma. Another easily discernible detail of magnification is the uneven distribution of the pigment, always a worrying detail. The pigment distribution has a vaguely chessboard pattern as in the penetrating nevus, but there is no a plexiform appearance of the neoplastic growth pattern. What is most striking is certainly the cellular growth. It is a compact growth pattern with obliteration of collagen fibers and the annihilation of all the anatomical structures of the dermis. At this magnification, we see a compact solid sheet of cells in which cells overlap each other. And this peculiar cellular growth allows us to be worried about the diagnosis.